Portal hypertension, an overview. Portal hypertension is a clinical condition characterized by an abnormally high blood pressure in the portal venous system, which includes the portal vein and its branches. The portal vein carries blood from the gastrointestinal tract, spleen, pancreas, and gallbladder to the liver. Normal portal pressure ranges between 5 to 10 millimeter Hg. Portal hypertension is defined when this pressure exceeds 10 millimeter Hg. Causes of portal hypertension. Portal hypertension typically results from conditions that increase resistance to blood flow within the liver or portal vein. These are broadly categorized as 1. Prehepatic causes, portal vein thrombosis, splenic vein thrombosis, congenital anomalies of the portal vein. 2. Hepatic causes. These involve increased resistance within the liver and are divided into pre-sinusoidal, sinusoidal, and post-sinusoidal types. Pre-sinusoidal, schistosomiasis, sarcoidosis. Sinusoidal, cirrhosis, most common cause, alcoholic hepatitis, chronic hepatitis. Post-sinusoidal, veno-occlusive disease. 3. Post-hepatic causes, Budd-Chiari syndrome, hepatic vein thrombosis, constrictive pericarditis, right-sided heart failure. Pathophysiology. The development of portal hypertension involves increased intrahepatic vascular resistance due to fibrosis, inflammation, or regenerative nodules in cirrhosis. Increased blood flow to the splanchnic circulation, which exacerbates the condition through hyperdynamic circulation. Formation of collateral vessels to bypass the high-pressure system, resulting in varices and other complications. Clinical features. Patients with portal hypertension may present with 1. Complications of collateral circulation, esophageal and gastric varices, risk of life-threatening gastrointestinal bleeding, caput medusa, dilated periumbilical veins, hemorrhoids, anorectal varices. 2. Ascites, accumulation of fluid in the peritoneal cavity due to increased hydrostatic pressure and hypoalbuminemia. 3. Splenomegaly, enlargement of the spleen due to increased splenic vein pressure, often leading to hypersplenism, anemia, leukopenia, thrombocytopenia. 4. Hepatic encephalopathy, neuropsychiatric disturbances caused by the accumulation of toxins, such as ammonia, due to impaired liver detoxification and shunting of blood away from the liver. 5. Other symptoms, fatigue, weight loss, jaundice, if liver function is impaired. Hack diagnosis. Portal hypertension is diagnosed based on clinical, radiological, and hemodynamic findings. 1. Clinical examination, detection of ascites, splenomegaly, varices, and other signs. 2. Laboratory tests, liver function tests, complete blood count to detect hypersplenism. 3. Imaging studies, ultrasound with Doppler, detects portal vein thrombosis, splenomegaly, and ascites. CT or MRI provides detailed imaging of portal vasculature and collaterals. 4. Endoscopy, essential for identifying esophageal and gastric varices. 5. Hepatic venous pressure gradient, HVPG, normal HVPG, flash 5 millimeter Hg, portal hypertension 5 millimeter Hg, clinically significant if 10 millimeter Hg. Management. The treatment of portal hypertension aims to manage the underlying cause, prevent complications, and control symptoms. 1. Lifestyle modifications, abstinence from alcohol in cirrhosis, sodium restriction and diuretics for ascites. 2. Pharmacological therapy, non-selective beta blockers, e.g. propranolol, nadolol, reduce portal pressure and variceal bleeding risk. Vasoactive drugs, e.g. octreotide, used in acute variceal bleeding. 3. Endoscopic interventions, endoscopic variceal ligation, EVL, or sclerotherapy for varices. 4. Radiological and surgical procedures, transjugular intrahepatic portosystemic shunt, creates a shunt to bypass the liver and reduce portal pressure. Surgical shunts or liver transplantation for refractory cases. 5. Management of specific complications, variceal bleeding, endoscopic banding, vasoactive drugs, and antibiotics for prevention of infection. Hepatic encephalopathy, lactulose and rifaximin. Ascites, paracentesis for large volume ascites. Prognosis. The prognosis of portal hypertension depends on the underlying etiology and the presence of complications. Cirrhosis-related portal hypertension has a poor prognosis, especially if associated with decompensated liver disease. Early detection and management can improve outcomes and quality of life. Portal hypertension remains a significant cause of morbidity and mortality, emphasizing the importance of prevention and timely treatment of liver disease.